Now you have a good understanding about the steps and the methods in systematic reviews, but let's shift our focus to a more specialized type of review, systematic reviews on values and preferences. Previously, we have introduced the methods in a systematic review regarding how to define a research question, how to systematically search literature, how to select eligible studies and extract data, as well as assess the risk of bias of eligible studies, and conduct evidence synthesis and assess the quality of evidence. However, unlike reviews that primarily examine the clinical effectiveness or health outcomes, values and preference reviews aim to understand how people perceive, experience, and prioritize different health interventions. These reviews explore what matters to individuals and communities. Because of the goal of the reviews are different, several key steps in the systematic review process also differ from what we have discussed so far. So let's explore. First, how to define research question. You have already heard many times in evidence-based medicine and guideline development, we need to consider or incorporate values and preferences. What does it actually mean? How do we define it in a practical way? When we talk about patient values and preferences, you will notice that there are many related concepts: patient experience, patient choice, utility, public values, expectations, involvement, and more. All of these reflect how people think about health, illness, and healthcare decisions. A useful way to think about this is as through an analogy. Patient values and preferences are like market research for health services. Just like companies want to understand what customers want, value, and expect, or what they will choose, healthcare systems need to understand that what patients care about, what outcomes matter to them, what trade-offs they are willing to accept, and what they consider important in their care. In previous videos about systematic reviews, we tend to understand the outcomes or the likelihood of outcomes, how likely is something to happen. For example, if we compare two treatments, we ask how many people will benefit, how many people will experience harm. This tells us what is likely to happen to patients after an intervention compared with an alternative option. But this is only part of the decision-making process. Imagine a situation where a treatment provides clear benefits and no harms. For example, in this PICO research question, should low molecular weight heparin versus unfractionated heparin be used in acute ill medical patients for venous thromboembolism prophylaxis? If everyone benefits from low molecular weight heparin compared with unfractionated heparin, that said, we have 40 VTE cases avoided and there is no increased risk for major bleeding. And in this case, values and preference don't really matter. The choice is obvious. We should all choose low molecular weight heparin. Now imagine the opposite. If the treatment causes harm and provides no benefit, in this case, assuming for every 1,000 patients, if using low molecular weight heparin compared with unfractionated heparin, there is no further VTE cases avoided, but there are 40 additional major bleeding cases. Then the choice is clear. We should all choose unfractionated heparin. But most real-life cases are not that simple. Usually, treatment comes with both benefits and harms. So some people may benefit, and some people may experience side effects, and there are trade-offs. This is where patient values and preferences become essential. Different people may value outcomes differently. Some may prioritize avoiding adverse events, and some may prioritize getting benefit from the treatment. So, decisions depend not only on what may happen, but on how important those outcomes are to patients. In summary, we need at least two types of information. The first type is about likelihood of outcomes, or what is likely to happen. And the second type is importance of outcomes. How much do people care about those outcomes? What matters to them? This is how grade defines values and preferences, as people value outcomes or how important those outcomes are to them. Here is another example. Should cell-free ctDNA blood testing, which we will call liquid biopsy, compared with tissue biopsy should be used to detect EGFR T790M mutation in people with advanced non-small cell lung cancer. To answer this question, we don't just need evidence about test accuracy and the long-term outcomes. We also need to understand what outcomes matter to patients. The outcomes related to this decision can be grouped into process outcomes. These related to how the test is done, such as burden of test, access to test, sensitivity and specificity, and privacy and autonomy, as well as short-term outcomes such as symptom relief, pain relief, side effects from treatment, and quality of life, and long-term outcomes such as life expectancy and overall quality of life. Different patients may value this outcome very differently, and some patients may strongly prefer a blood test because it is less invasive and causes less discomfort. Others may prioritize the diagnostic accuracy even if the test is more burdensome. And some people may focus on avoiding anxiety, and others may care more about long-term survival. So again, the decision is not only about what outcomes happen, but also about what outcomes matter most to them. So, here to conclude the first part, when we define a research question for values and preferences systematic review, we shift our focus. Instead of asking a pickle question, we ask how do people value the outcomes of some interventions or some conditions, or what are the values or importance that people place on the outcomes. As for searching for values and preferences, the choice of databases, the search for great literature, and the use of Boolean logics, they are the same. However, it is very challenging to search or to use the concept of values and preferences to develop such strategies. As we can see, there are so many related concepts. This slide shows some examples of how we use terms to search values and preferences. And one thing to understand is that these terms can be very broad. We often include general concepts such as attitude to health, patient participation, preferences, or patient preferences. These terms help us capture studies that explore how people think, feel, and make decisions about healthcare. But the values and preferences could also be about user participation, patient perspective, user views, patient views. And in addition to conceptual terms, we also search for specific methods that are used to measure values and preferences. For example, feeling thermometer, best worst scaling, or time trade-off, probability trade-off. These techniques are often used in quantitative studies to measure how people value different health outcomes or trade-offs. And sometimes we go even broader. We may use quality of life measures such as EQ5D, SF6D. These tools don't always measure preference directly, but they reflect how people value different health states. So they can provide useful information about what outcomes matter to patients too. The key takeaway is this. Searching for values and preference studies requires a broad and flexible strategy. For your own values and preferences systematic review, there are some examples for you to learn more about literature search. You may adapt these search strategies for your own research project. Now let's talk about what are eligible studies for values and preferences systematic review. Because values and preferences can be defined very broadly, as the importance people place on outcomes. Many different study designs can be relevant. For example, this slide shows we can put studies into different categories such as utility, trade-off, other quantitative results, and qualitative results. All this could help us understand how people value health outcomes, but they do so in different ways. Some studies use numbers, some use choices between options, others use people's own words and experiences. All of this can be valuable in a values and preferences systematic review. Let's start with utility. Utility is a numerical way of representing how desirable or undesirable a health state is. Values usually range from 0 to 1, where 1 means perfect health and 0 means a health state equivalent to death. One common way to measure utility is the time trade-off method. In a time trade-off, people are asked something like, would you rather live a longer time in a poorer health state or a shorter time in perfect health? By seeing how much time people are willing to give up, we can estimate how they value different health states. This tells us how people balance quality of life against quantity of life. Another common type of study focuses on trade-offs between benefits and harms. For example, people might be asked how much of an increase in bleeding risk would you accept if your risk of stroke decreased by 3%. Here, the focus is not just on utility scores, but on real-world decisions. These studies show what risks people are willing to accept, what benefits they prioritize, how they weigh competing outcomes. This type of evidence is very helpful for guideline panels because it reflects the kinds of trade-offs patients actually face. Not all quantitative evidence use utility or formal trade-off methods. Some studies simply ask people to rank or select what matters most to them. For example, in people with COPD, researchers may ask, what are the most important characteristics of an ideal treatment? And the result might show that faster symptom relief, longer time between flare-ups, fewer side effects are important than cost or dosing convenience. These results still tell us about patient priorities or values and preferences, even if they don't use formal preference elicitation techniques. We also have qualitative studies. These studies explore patients' experiences, feelings, and perspectives through interviews or focus groups. For example, for patients who are using warfarin, most participants had not experienced complications. Many reported only minor inconveniences, such as taking a pill every day, regular blood tests, and dietary changes. This type of evidence helps us understand what people find burdensome, what they consider acceptable, how treatment affects daily life. Qualitative data adds depth and context that numbers alone cannot provide. That said, just like the literature search for values and preference studies, you may have to adapt the eligibility criteria to fit with your research goal specifically. What are your research goals? Are you supporting a guideline development? Are you supporting an economic evaluation that you need utility values? Or you are trying to understand the experiences of patients with some conditions? Different research objectives may determine your eligibility criteria. Now let's talk about how to assess the values and preferences studies, how to assess their risk of bias. We have developed the ROB value tool to assess the risk of bias in studies about people's values, utilities, or importance of health outcomes. Notably, because we do not need randomization to balance the known and unknown prognostic factors, this risk of bias assessment tool does not consider the randomization process. It focuses on four main domains. The first is how were participants selected. We look at the sampling strategy. Were participants representative of the population of interest? For example, random or stratified samples usually have lower risk of bias than convenience samples. Second, was the study complete? We check the response rate and loss to follow-up if it is a longitudinal study. And if many people didn't respond or dropped out, the results may not reflect the true range of patient values. Third, how were values and preferences measured? We assess whether the measurement tool was valid and reliable. This includes methods such as time trade-off, discrete choice experiments, or quality of life instruments. We also consider whether participants understood the questions and whether health states were clearly described. And we also consider how was the data analyzed. We look at whether appropriate methods were used and whether important factors such as age, disease severity, or prior experiences were considered in the analysis. In summary, Robert value helps us judge who was included, who responded, how values were measured, and how results were analyzed. This tells us how much confidence we can place in the findings from values and preferences studies. Just like in effectiveness systematic reviews, our goal is to summarize the available evidence in a transparent and systematic way. However, the type of evidence synthesis we use depends on the data. In some cases of systematic reviews on values and preferences, meta-analysis is feasible. For example, when studies report comparable utility values using similar instruments and health states definitions, we can statistically pool the results. This slide shows an example of a meta-analysis of utility values in people with COPD, grouped by disease severity. Each study provides an estimate of how patients value their health states, and these estimates are combined to produce a pooled value. This approach of meta-analysis helps us summarize the results across studies and reduce random error and identify patterns across populations. But meta-analysis is only appropriate when the data are sufficiently similar. In many values and preferences systematic reviews, meta-analysis is not feasible. Studies often differ in measurement tools, outcome definitions, reporting formats, populations, and contexts. In these situations, we use narrative evidence synthesis instead. This slide shows an example of a narrative synthesis focused on how important breathlessness is to patients with COPD. Here, results are organized by study, measurement instrument, report format, key findings, but note this is all information about outcome importance for one particular outcome, breathlessness. Rather than pulling numbers, we describe patterns, similarities, and differences across studies. Please note that narrative evidence synthesis is not just a summary of opinions. It follows the same systematic principles used in effectiveness reviews, such as those described in the Cochrane Handbook. This means the goal of evidence synthesis, even it is narrative, not quantitative polling, is still to provide a rigorous and reproducible synthesis of evidence. In this final section, I will talk about quality of the evidence. Quality of evidence, as we have introduced before, is about the confidence in effect estimate. It means how confident we are that the available evidence is adequate to support a particular decision or recommendation. In the context of values and preference reviews, it means how confident we are about the estimates of the importance of outcome. For example, how confident we are that the patient truly prioritizes avoiding breathlessness, or that they are willing to accept certain risks. So here, quality of evidence reflects our confidence in the findings about the importance of outcome and our confidence in that the evidence is adequate enough to support a particular decision or recommendation. The process for rating quality of evidence in values and preferences reviews follow the same general rationale as evidence review for treatment effects. However, there is one important difference. Because values and preferences studies do not aim to create balanced comparison groups, we do not require randomization. So, non-randomized evidence still can start at high quality. From there, we consider whether to lower our confidence based on 5 domains. Risk of bias. Were the methodology sound? Inconsistency. Do results vary a lot across included studies? Indirectness. Do the studies match the population and the context that we care about? Imprecision. Are the estimates uncertain or based on small sample size? Publication bias. Are some results more likely to be published than the other? After considering these domains, we rate the overall quality of evidence as high, moderate, low, or very low. So, with that, we have now covered the full process of conducting a systematic review of values and preferences, from defining the research question to synthesizing and rating the evidence. To conclude, let's return to this overview of what a systematic review involves. In any systematic review, we define a research question, systematically search the literature, select eligible studies, and extract data and assess the risk of bias. We synthesize the results and then assess the overall quality of the evidence. Values and preferences systematic reviews follow the same rigorous process, but there are some important differences we have emphasized with this video. First, the research question focuses on what matters to people, not just what works. We ask how patients value outcomes and what trade-offs they are willing to accept. Second, the search strategy needs to be broader. We include terms related to values, preferences, experiences, participation, and even some quality of life measures. Third, eligible study designs are more diverse. We include utility studies, trade-off studies, other quantitative results, and qualitative research. Fourth, risk of bias assessment focuses on sampling, response rate, measurement tools, and analysis methods that affect how well preferences studies are conducted and preferences results are captured. Fifth, evidence synthesis may involve meta-analysis when data are comparable, but often relies on structured narrative synthesis. And finally, quality of evidence reflects our confidence in conclusions about the importance of outcomes. So, while the framework of a systematic review stays the same, values and preferences reviews are designed to capture the human side of healthcare decision, what people care about, how they weigh benefits and harms, and what truly matters to them. Thank you for watching.